Good evening, doctors. My name is Rakesh Sonane, and on the behalf of FDC and MedTalks, I would like to welcome you all. After 2 months of successful execution of topical fever sessions, we are back to our diabetes essential section. And today's session topic is diabetes and the pituitaries. Before going forward, I would like to announce last week quiz winners. They are as follows: Shantanu Kumar Bhattacharya from Kolkata, Gangadhar Rath from Bhubaneswar, Dr. Sujit Kalsi from Noida, Lukesh Jandial from Panvel, Raju Handa from Delhi, Kaval Saluja from Mumbai, Ravi Bhatt from Sirsi, Shashi Khare from Bhopal, Dr. Bimla Kapoor from South Delhi, Anand Purandare Mumbai, Mitali Das Navi Mumbai, Lakshmipati Bhupati Vellore District, Ramesh Hegde from Bangalore, Satish Kumar Jain from Bangalore, Sumita Sharma from New Delhi, Ashutosh Das from Tamluk, and Sanjeev Puri from Hoshiarpur. With this, I would like to hand over this session to Dr. Sanjay Karla, sir.
Thank you, Mr. Rakesh, and good evening, everybody. It's a great feeling continuing this series of diabetes essentials. And another feeling, a good feeling, is that we've been talking about tropical fevers for the past 2 months. We are coming back now to our core theme of diabetes. Last week, if you remember, we spoke about diabetes fever, and Dr. Suneet Verma took us through the various causes of fever in diabetes and also how fever itself impacts diabetes complications or diabetes presentation. Over the next couple of months now, we'll be talking about hardcore endocrinology. We'll talk about how endocrinology and diabetes practice are amalgamated with each other. And today, our topic is diabetes and the pituitary. The pituitary and diabetes. A warm welcome to Dr. Vedant Kulkarni. And I'm finding it difficult to move my slides, but now I've managed. Yes. And pituitary is very important because pituitary and diabetes, the relationship actually won Bernardo Husse a Nobel Prize in 1947. He was able to decipher the link between the adenohypophysis, that is the anterior pituitary, and glucose metabolism. This was 1947, and he shared the Nobel Prize with the Corey team, husband and wife, who had also worked on glycogen metabolism, on metabolism related to glucose. Let's just remind ourselves, and a warm welcome to Dr. Vikas Sonavane. Let's remind ourselves of the anatomy of the pituitary gland. There is an anterior gland and also a posterior lobe. There is a mid lobe as well, but that is not physiologically important. So the anterior lobe produces hormones such as TSH, growth hormone, prolactin, ACTH, LH, and FSH. All these may impact glucose metabolism, but growth hormone specifically and ACTH both have direct impact on glucose metabolism through their target glands. The posterior lobe of the pituitary gland produces two hormones, oxytocin and vasopressin. These do not directly cause diabetes or hypoglycemia, but they also have strong role to play in glucose homeostasis. Now that we've seen the anterior and the posterior lobe of the pituitary, let's see what happens in hyperfunction. Now, if there is hyperfunction of the anterior lobe, depending upon which cells are increased in number and in function, we may have acromegaly, that is excessive growth hormone. In a child whose bones are not fused, the term that we use is gigantism. When the bones are fused in an adult, growth hormone excess will lead to acromegaly. If it is the corticotrophs that are hyperfunctioning, then you get Cushing's disease. Cushing's syndrome can be multiple etiologies. Cushing syndrome, for example, can be of pituitary etiology, adrenal etiology, non-adrenal etiology, extra-adrenal, unknown etiology. It can also be exogenous. But if the etiology is in the pituitary gland, we term it as Cushing's disease. You also may have a prolactin secreting pituitary adenoma and TSH secreting pituitary adenomas. Acromegaly and Cushing's disease are directly linked with hyperglycemia. TSH secreting pituitary adenoma theoretically can cause insulin resistance because in Graves' disease also we have insulin resistance. But there is no known case of diabetes occurring because of a TSH secreting pituitary adenoma. However, do remember that whenever T3 and T4 are increased, such as in uncontrolled Graves' disease, glucose levels will go up. Prolactin secreting pituitary adenoma may also be associated with insulin resistance. Now, let's come to the posterior lobe. The posterior pituitary secretes oxytocin and vasopressin. Oxytocin in general is a good hormone. It's a friendly hormone. It's a maternal hormone. It speaks about friendship. So therefore, we can remember easily that oxytocin helps in improving insulin sensitivity. But whether this fact will be clinically relevant, will an oxytocin injection, for example, lead to hypoglycemia? That is questionable. Vasopressin deficiency causes diabetes insipidus. And vasopressin does influence glucose metabolism. But again, these are biochemical constructs. It is doubtful that a patient with diabetes insipidus or with SIAS, that is a syndrome of excessive vasopressin secretion, ADH secretion, will cause diabetes or hypoglycemia. Let's revise all the possible impacts that may occur in anterior pituitary dysfunction, both hyper as well as hypofunctioning. If there is growth hormone hypersecretion, you will have insulin resistance and there may be diabetes. In fact, there are studies which show that in people with acromegaly, around 35 to 50% of all individuals have dysglycemia or diabetes. People with excessive ACTH secretion, that is Cushing's disease, will also have impaired glucose tolerance and diabetes. So these are two important causes of secondary diabetes: excessive growth hormone, excessive ACTH. What does this mean for us? We'll discuss later, but even now, let's remind ourselves that in case you have a person with diabetes, it is not necessary that that patient will have type 2 diabetes. If you find that the clinical picture is a bit different from what you are used to seeing, it's not the typical kind of type 2 diabetes that you see, do think about secondary diabetes. It is also not necessary for the physician to do all the investigations, but at least we have to think. We can at least do a clinical examination, take a history, and see if there is anything suggestive of growth hormone or ACTH hypersecretion. In prolactin hypersecretion, uh, in prolactinoma, small studies have shown that fasting hyperglycemia is increased. And some people say that even with patients with physiological hyperprolactinemia, there may be insulin resistance. On the other hand, there are other studies which say that prolactin hypersecretion is associated with hypoglycemia or increased insulin sensitivity. TSH we've already mentioned. It's not because of TSH hypersecretion per se, but it is because of increase in T3 and T4 that you may encounter insulin resistance and worsening of pre-existing diabetes. The opposite end of the spectrum is hyposecretory conditions, and patients with pan-hypopituitarism are prone to hypoglycemia, not only drug-induced but spontaneous as well. So if you find that a person has suddenly begun developing spells of spontaneous hypoglycemia, there can be many causes. It might be an insulinoma, but it also might be panhypopit or growth hormone deficiency. Speaking of growth hormone deficiency, in children, growth hormone deficiency is associated with increased insulin sensitivity and fasting hypoglycemia. So when the child wakes up in hypo. In adults with growth hormone deficiency, however, there is insulin resistance. Even in people with hypogonadotropic hypogonadism. So in men with hypogonadotropic hypogonadism, you will have insulin resistance, increased adiposity, more of metabolic syndrome. There is also a syndrome known as functional hypogonadotropic hypogonadism. We don't use this term frequently in internal medicine. The terms that we use are andropause, late onset hypogonadism, and this is quite common in men with type 2 diabetes, in middle-aged men with type 2 diabetes. These people not only have insulin resistance, impaired glucose tolerance or dysglycemia, they also have increased adiposity, poor cardiovascular outcomes, and low testosterone levels. with nearly normal LH and FSH. Now, this was one aspect. We are talking today of the pituitary and diabetes. We have seen that hyperfunctioning and hypofunctioning of the pituitary may be associated with dysglycemia. And actually, it is this work for which Husse won the Nobel Prize. But when you treat the pituitary using drugs, even then you run the risk of worsening glucose metabolism. When we replace growth hormone with growth hormone, uh, some people actually end up developing impaired glucose tolerance and diabetes, especially the initial years of therapy. In children, also, when we start growth hormone, there may be a subtle insulin resistance, though the risk of new onset diabetes is rare. We use drugs, we call them somatostatin analogs. First generation somatostatin analogs are octreotide and lanreotide. These are used for a multitude of indications, and they are associated with postprandial hyperglycemia and increase in HbA1c. Pasireotide is another drug that is used, and it can be associated with uncontrolled hyperglycemia and new onset diabetes. The treatment of choice here is incretin based therapy because pasireotide is known to suppress the incretin response. Pegvisomant is a growth hormone receptor antagonist. A growth hormone receptor antagonist, and because it antagonizes the effect of growth hormone in acromegaly, it helps improve glucose levels. Bromocriptine and cabergoline are drugs that have been used historically and conventionally both for the management of high prolactin levels. But a drug was developed and we used it a lot in India about 15 years ago. Bromocriptine quick release formulation was prepared. You had to take it within 2 hours of waking up. I think it was 2.4 milligram. And this was the first, in case you want to go for a quiz, and this is not our quiz question for today, uh, which was the first glucose lowering drug to be approved by the FDA after the release of new guidelines in 2007 or 8, which asked for cardiovascular outcome trials. And the answer is bromocriptine quick release or bromocriptine timed release. That's the correct answer. This was used for the treatment of diabetes. The results were modest, around 0.4, 0.5% HbA1c loss reduction, and that's why it went out of favor. Cabergoline continues to be used today for the management of high prolactin levels. There are reports of improvement in weight, insulin sensitivity, and glucose levels, but cabergoline is not used routinely as a glucose lowering medication. GnRH analogs are being used more and more frequently in pediatrics, in gynecology, and also in urology. GnRH analogs are drugs that are used for what we call medical castration in patients with CA prostate. And these run an increased risk of diabetes. So if you have anyone, any gentleman or any lady who is on long-term GnRH analog therapy, do keep on screening regularly for dysglycemia. Mifepristone is an abortifacient which is also approved for the treatment of hyperglycemia in Cushing syndrome. So it's a rare indication, but it can be used to manage hyperglycemia in Cushing syndrome as well. And micasermin is a drug which is associated with hypoglycemia. Therefore, it must be taken with food. You cannot take it on an empty stomach. Now, we first spoke about the impact of hyperfunctioning and hypofunctioning of the pituitary on glucose metabolism. Now we have spoken about the impact of drugs on glucose metabolism, drugs that we use in diabetes, that we use in pituitary care. And now I think something is wrong with my slide changer because it's just not moving. Let me try again. Forward. No. Oh yes, it moved. Yeah, you keep on. This is uh, this is what persistence is all about. I hope you can see the slide. Let's talk about practical considerations now. What is it that we need to do in the OPD? The first thing is that whenever you have a patient with diabetes, you need to identify the etiology. You may not be able to identify the etiology in every patient with diabetes. Even I am not able to do that. None of us is able to do it in all our patients. You have to tell your patient that we are treating you today, but diabetes is a long term disease, and we may change the diagnosis of type of diabetes over time in a longitudinal manner. If, however, you suspect secondary diabetes or you feel that something is wrong somewhere, uh, do screen for pituitary disorders, especially growth hormone and cortisol excess. Vice versa, in patients with known acromegaly, Cushing's disease, and perhaps a TSH secreting pituitary adenoma, it would be a good idea to screen for diabetes at regular intervals. In case any person is being treated with first generation somatostatin analogs like octreotide, again we have to screen for dysglycemia regularly. If patients are not doing well from a metabolic point of view on first generation SSA like octreotide, it may be a good policy to think about switching over to pegvisomant. Second generation SSAs like pasireotide also worsen glucose levels, and here the drug of choice would be incretin based therapy. For patients on Cushing's disease who find it difficult to manage their diabetes, you can always think of mifepristone. So these are practical points. Be vigilant. The term used by Bhattacharya et al. Is hypophysiovigilance. Be vigilant regarding pituitary disease in people with diabetes, and be vigilant regarding dysglycemia in people with pituitary disease. That would be our take home. It's not that you have to be vigilant just about hyperglycemia, also hypoglycemia. If a patient presents to you with hypoglycemia suddenly in the OPD, someone on diabetes therapy, the first thing we think of is medical causes: renal impairment, hepatic impairment, gastrointestinal impairment. But do not forget endocrine causes. They are quite common: hypothyroidism, hypoadrenalism, hypothyroid, adrenal dysfunction or Addison's disease, and hypopit, panhypopituitarism. This is common in children, but it can occur in adults as well. Some common causes are snake bite, Sheehan syndrome, which will occur after postpartum hemorrhage in women who have delivered. So you should always take a history of endocrine aspects of health, maybe a menstrual history, sexual function, sexual dysfunction. These will give you an idea regarding whether you have to think about pituitary or not. In children, failure to thrive, panhypopit may be a cause of that. Another practical consideration is that if you have a person who has diabetes, a middle-aged male, it is possible that the person may have hypogonadism, and hypogonadism can be hypergonadotropic or hypogonadotropic. So do screen for hypogonadism in people with diabetes. There may be some patients who take glucocorticoid replacement therapy, growth hormone replacement therapy, even testosterone replacement therapy. Be aware of the potential to increase insulin resistance and hyperglycemia with all these drugs. Patients who are on prednisolone or methylprednisolone will usually have a peak glucose post lunch or pre dinner. What this means for us is that we have to give some kind of treatment at lunch. It might be a short acting insulin, it can be a short acting sulfonylurea like glipizide, it can be an even shorter acting secretagogue such as repaglinide, and it might be the humble acarbose. Acarbose will also it will help to reduce the postprandial rise after lunch. So, depending upon the needs of the patient, you can choose any kind of treatment, but usually some kind of a treatment will have to be given at lunch. Some people are not able to take that, and another option is to give NPH insulin twice a day for patients who need glucose control while they are on prednisolone or methylprednisolone. When you give NPH twice a day, you are able to control both fasting and postprandial glucose, especially the post lunch glucose. There are other aspects also of physiology, though they are not very important from a clinical perspective. We've already mentioned that diabetes can impair the gonadal axis, can be associated with hypogonadism in men. It can also be associated with alterations in IGF-1, IGF-2, and IGF-3, especially in people with type 2 diabetes, and it might affect the prolactin and cortisol axis. One last aspect when we talk about pituitary and diabetes, there are various syndromes that can affect both glands together. Wolfram or Didmore syndrome is associated with diabetes insipidus and diabetes mellitus, along with optic atrophy and sensorineural hearing loss. Prader-Willi syndrome is a hypothalamic cause of obesity associated with hyperphagia, hypopit, and diabetes. Maternal diabetes, you're all aware of, mitochondrial diseases, uh, which are of maternal inheritance, can present with both diabetes and deafness and growth hormone deficiency. And we may have multiple endocrine neoplasia, which affect the parathyroid, the pituitary, and the pancreas. So, this in a nutshell was our discussion about the pituitary and diabetes. And this is the first in our series for the next couple of weeks about various glands, the various endocrine glands, and their relationship to diabetes. A warm welcome to Dr. Pradeep Rawal from Ujjain in Madhya Pradesh, and as well as Dr. VK Goyal. It's always great being with you. Let's come to our questions for today. So, our first question, pituitary apoplexy. Now, what does this mean? Pituitary apoplexy is associated with diabetes insipidus, hypertension, high blood pressure, sickle cell anemia, or all of the above. What you feel is right. Pituitary apoplexy is associated with diabetes insipidus, hypertension, sickle cell anemia, or all of the above. Remember that out of all the glands in the body, it is perhaps the pituitary, perhaps which has the densest vascular supply per gram of weight. So the pituitary cannot live without blood supply. Our second question, diabetes insipidus. Now this question is related to the posterior lobe of the pituitary. Diabetes insipidus is due to a deficiency in the production of ADH, antidiuretic hormone, often resulting from damage to the pituitary gland. It is marked by expelling excessive quantities of highly dilute urine, extreme thirst, and a preferential craving for cold water. Which is correct? Is diabetes insipidus due to a deficiency in ADH production? Is it marked by excessive micturition, extreme thirst, and craving for cold water? Or is it both of the above, or perhaps none of the above? That's our question. DI is due to ADH production deficiency. DI is associated with increased urination, thirst, and craving for cold water. Both of the above, or none of the above. These were our questions for today, our quiz questions, and we look forward to your answers. In the meanwhile, we have one question from Dr. Vilas Sonavane. Warm welcome, sir. And Dr. Sonavane asks, a patient on basal bolus insulin taking ultra short acting insulin 3 times a day, 688, and basal insulin is 40. Okay. Now, very well controlled. He wants to shift to 2 doses. What would be a good idea? Now, one surprising thing is that here the total number of bolus units is 6 plus 8 plus 8, which is 22, and the basal insulin is 40. That is a bit surprising, 1:2 ratio. Usually it should be the other way around, or maybe 60% of bolus and 40% of basal. But still, if the patient wants to sort of try, what I would do in the OPD is maybe I would say let's continue uh, 6 and 8 units at breakfast and lunch, and let's try 48, but that would be too much. Uh, Maybe 40 units of a co-formulation at dinner time. The co-formulation would be aspart plus uh, degludec. If the patient does well on 3 doses, we can always try to shift to 2 doses. The total calculation, I'm counting now 62 units per day. So maybe something like 27 or 28 units of degludec plus aspart twice a day. For lunchtime, now we are not very sure if this patient has type 1 or type 2 diabetes. Both ways you can use acarbose, whether it is type 1 or type 2. And if it is type 2, you might want to also use a DPP-4 inhibitor at lunchtime along with metformin. But that will depend upon the clinical picture. But we can try, Dr. Sonamne. From 4 dose, you shift to 3 and then you go to 2. Good evening to Dr. Vedant once again. And Dr. Nitin Rulla is taking sitagliptin 100 plus metformin 500. Sitagliptin 50 is a dose only for people with renal impairment. So if your kidneys are fine, if the EGFR is above 50, you should continue 100 milligram. Otherwise, that will be suboptimal dose and glucose levels will begin to rise sooner or later. And if TSH is generally less than 1, like Dr. VK Goyal says, and there are no symptoms, there is no problem at all. Just make sure that you take calcium, vitamin D as per your requirement, as per your age group's requirement. So it's been great speaking with you about the pituitary today, and I look forward to further events. It is also festive season, and before I conclude and hand over to Mr. Basu, congratulations to everybody on our team's win yesterday in the World Cup. Thank you.
Thank you very much, sir. As we have already seen that Dr. Kalra has said that he has come back to the core of Diabetes Essential Season 3, and we will continue next couple of weeks on the different glands and their impact on diabetes. This journey continues to go with along with Dr. Sanjay Kalra and the viewers which we have achieved in last 3 years. I hope with the continuation of this, we will be achieving our objective of increasing the awareness of screening and treating the patients much better than what we are doing today. There is a question, sir. Would you like to take? Dr.
Yeah,
Mahendra is
sure.
asking.
Yes, I'll do that. So Dr. Mahendra says, what type of insulin regimen is best for a patient who has normal fasting but more postprandial, and vice versa? So if the fasting glucose is high, then our choice should be basal insulin. Try basal insulin first with whatever oral drugs the patient was taking earlier. You can give sulfonylurea and basal insulin together. It's called BIDS regimen. And if glucose levels improve, that's fine. Otherwise, we can move to premixed insulin. If, however, postprandial glucose is very high, then maybe the drug of choice would be prandial insulin or bolus insulin 3 times a day. But we very rarely use that in India. One indication in my practice might be gestational diabetes. Some of my patients are well controlled on that. In Germany, we are told that bolus regimen like this is quite popular. It may be a difference in their lifestyle or in their meal patterns, I'm not sure. But that is the only major country where bolus insulin is used alone without basal. In India, what we would prefer would be premixed insulin. That would be convenient for those of us in private practice. So it will help control both postprandial and fasting glucose. Start with something like 10 to 12 units twice a day, Dr. Sharma. Maybe zero point 0.2 units per kg body weight if you want to get better control. Your average control will achieve, your average patient will achieve control on zero point 0.4 units per kg per day. That would be the average. So start at 10 to 12 units twice a day or maybe zero point 0.2 units per kg per day. Tell your patient that when we are starting insulin, the first thing that you will experience is symptomatic relief and anabolic effect. After that, the postprandial glucose will come down and then the fasting will come down. And tell the patient it may take 10 to 12 days. That way, the patient doesn't argue with you when they come back for a 7 day follow up.
Thank you,
There was
sir. I think with this, we have come to the end of today's. Yeah.
Yeah,
Question,
but
sir? Any?
Mr. Nitin, I would sincerely request that I am very sure I have answered this question. अब नितिन मेरी मेमोरी भी कम हो रही है, मेमोरी प्रोसेस हो रहा है, पर इतनी मेमोरी कम नहीं हुई. अगर साइकोलॉजिकल मानते हो तो साइकोलॉजिकल ही होगा नितिन भाई, फिर अब क्या करें हम फटीग का. But I am very sure that we have discussed this multiple times in our earlier talks.
So with
And
this, we
यदि
have come.
अभी भी नितिन अगर फटीग नहीं जा रहा तो humble request कि एक दिखा दो ना एक डायबिटोलॉजिस्ट को फिर.
With this, we have come to the end of today's talk of Dr. Sanjay Kalra. And as usual, Dr. Kalra is so humble enough to take the last minute questions also. But we also have designed that on every 20th of the month, we have NRSDAL 0 day doctors' questions, which we collect across India. And those questions we send it to Dr. Kalra on coming sessions. So that will be also be available. So if any questions are there with you, 20th November, we will be coming and taking the questions from you, from your side. With this, I sincerely thank Dr. Sanjay Kalra for taking the session. And with this, Jai Hind and good night, sir.
Jai Hind.